My name is Peter Novak. I'm from Boston, working at Brigham Hospital, and I run autonomic laboratory. And in the next few minutes, I will talk about neurological complications of Lyme disease. Here are my disclosures. And the learning objectives of today's speak will be to be familiar with neurological complications of Lyme disease, to understand the concept of post-treatment Lyme disease syndrome, to understand the current status, including immune mechanisms implicated in Ptlds, and I will mention several off-label medications. Acute Lyme disease, however, can affect different aspects of the neural system, and actually can affect all neural structures. It can affect the peripheral nerves, causing mononeuropathies or simultaneous affection of the several nerves, or it can affect the central nervous system, and it can affect the brain, meninges, cranial nerves, spine, or combination of above. One problem with Borrelia is of CNS, it is difficult to recognize because only 14 patients recall the tick bite in the site of the rash, but still the presentation is relatively well-defined and straightforward, and most patients, they respond to medication, either oral or IV. And most of these patients are being treated by primary physicians or infectious disease specialists or neurology. But I like to focus this presentation mainly to post-treatment Lyme disease syndrome. Everybody who treats a Lyme disease knows that not everybody will recover. And this is actually a definition from CDC, a website. It says that almost most cases of Lyme disease can be cured within 2 to 4 weeks of course of oral antibiotics. Many patients can sometimes have symptoms of pain, fatigue, difficulty thinking that last more than 6 months after they finish the treatment. And this condition is called post-treatment Lyme disease syndrome, Ptlds. And according to CDC estimation, 10 to 20% of Lyme disease patients develop Ptlds, although there are some estimation up to 50% have some complications of the Lyme. The Ptlds can be schematized as a combination of 3 main complaints. It is brain fog, fatigue, and the pain. This is very nice recent review by Dr. Okot from Hopkins, which try to explain the Ptlds, and even if it is not known, they put forward hypothetical possibilities why people with post-Lyme disease develop complaints or problems, and a combination of immune mechanisms, persistent antigens, and neural network. For some reason, a Lyme disease may alter the structure of the brain, and this leads to sensitization and complaints, including cognitive difficulties. There is some evidence, which I will talk about later, that immune system might participate in the Ptlds, as patients with have increased number of the inflammatory markers in the serum or CSF. And another theory hypothesizes that Ptlds results from either persistent organisms inside the cells or undertreated acute Lyme disease. And I would add also here that there is also increasing importance of the co-infections. Up to 55% of patients with acute Lyme disease, they also might have positive markers for co-infections like Bartonella, Babesia, or Powassan virus, or others. This is another review came from Lyme disease organization, exploring the complaints after patients with treated Lyme disease. And the author decided to use the term chronic Lyme disease. Even this needs to be, it's not accepted in all community. But the main point of this study is that in addition to multiple complaints affecting different systems, the severity was striking. Most of these complaints were up to severe, which means they are severe interfering with quality of life. Now, I would review several studies showing how immune system might be involved in PTSDs. And this is probably the most important study by Dr. Okot, again from Hopkins. This is important study because it is a prospective study. They enrolled 76 patients with erythema migrans, and they measured inflammatory markers over the time. And they used standard Lyme criteria, which is patient-documented erythema migrans, together combined with evidence of dissemination, so multiple skin lesions or new onset concurrent systemic symptoms, etc. And this is very important what they find out, that only 46 patients of the which developed PTLDS were seropositive, which indicates that serological markers are really not perfect. PTLDS was observed in 14.5% of patients, which is to be expected. And what is very important or interesting in this study, they did find out that one inflammatory marker, the lymphokine CCL19, was elevated not only at the beginning, as a pre-treatment period, but was elevated throughout the treatment, throughout after the Lyme disease, up to 1 year of the treatment. And this elevation was observed in patients with PTLDS defined as a presence of clinical symptoms. So this study has a couple of implications. First, it does show that patients with PTLDS, they do have abnormal autoimmunity. Second, this also shows that elevated CCL19 can be a marker of the PTLDS, which is very important how to differentiate of the patient with PTLDS for other conditions. And also third, this marker might be used as a biomarker of response to treatment. However, this study needs to be replicated. This is another interesting study. It is known for many years that central inflammation results from activation of glial cells. Recently, the imaging modalities were developed to measure glial activation in vivo. And this study looked on the patients with PTLDS, and they enrolled 12 patients, and they measure the glial activation using the new developed markers. And what they did find out that indeed glial cells were activated in several areas of the brain, which again support the role of the immune activity in PTLDS. This is example of the study showing increased glial activation in several areas of the brain. Although the increased activation was very mild, but it seems to correspond to the area which might be implicated in the cognitive problems of these patients. As again, with the previous study, this needs to be replicated, but the glial activation markers are more and more widely available in large medical centers. And this is another study. This is coming from our lab, and we look on the association between small fiber neuropathy and post-treatment Lyme disease syndrome. The reason for this was that many patients with PTLDS, they do complain on several pain syndromes, including burning sensation or fluctuating paresthesia, which are typically seen in the damage of the small fibers. So in this single center study, we did a retrospective analysis of patients with PTLDS. We performed skin biopsy for assessment of epidermal nerve fibers, which are sensory fibers, We also look on the thread glandular fiber density, which are autonomic fibers. And we also performed functional autonomic testing, those are standardized evaluations, and we evaluated cerebral blood flow, CO2, mark of respiration, blood pressure, and heart rate. We enrolled 10 participants, 5 male, 5 women, age 51 year average. And we spent significant time to review each patient to make sure that they satisfy CDC criteria. It means that everybody has to have at least 5 abnormal IgG bands. And the results that show significant abnormalities essentially in everybody. Abnormal EMDF means abnormal skin biopsy, evaluating sensory fibers was abnormal in 9 participants. Abnormal skin biopsy for evaluation of the autonomic fibers in 5 participants. And both sensory and autonomic fibers were detected in 4 participants. We also found parasympathetic failure in 7 people and mild to moderate sympathetic failure in all participants. Mild to moderate means that they did have some abnormality in blood pressure regulations, but they did not have orthostatic hypotension, which is mark of more severe autonomic failure. But this is one of the most abnormal findings. We found abnormal blood, cerebral blood flow in everybody. 7 patients had abnormal orthostatic cerebral blood flow, and 3 remaining patients had an abnormal reduced supine blood flow. So we concluded that small fiber neuropathy appears to be associated with Ptlds and may be responsible for certain sensory symptoms such as pain and burning sensation. Dysautonomia is frequent in Ptlds, but it is mild, and I would say probably not responsible for most of the symptoms. However, reduced orthostatic cerebral blood flow velocity can be associated with cerebral hypoperfusion and may lead to cognitive dysfunction, and particularly we think it might be somewhat linked to brain fog, which is very common in Ptlds. I would just show the number of medications which patients were on, and it was striking complexity of management. Most patients were on the multiple medication, either oral or intravenous, and they were on this medication for multiple months. And here the table shows basic demographic of our patients. This is age and gender, BMI. But this table shows the IgG bands, and it was a requirement for the inclusion in the study that at least 5 IgG bands were positive, because we want to make sure that people indeed had Lyme disease. And here are main findings of the study. Those are self-reported questionnaires. This is pain questionnaire, and this is autonomic questionnaire. 0 means no symptoms. The higher number, the more symptomatic they are. And this shows skin biopsy results for each patient. Those are sensory fibers. This is a number of the fibers per millimeter, and those are normative values adjusted for the age and gender. And here we see the autonomic fibers on the skin biopsy. But one of the most important results is this cerebral blood flow, means that cerebral blood flow was abnormal in everybody. 0 means normal, up to 10 is severe abnormality. Even it is not a moderate abnormality, but it is present in everybody. And this is total score. So we concluded that we found reduced cerebral blood flow velocity in all Ptlds patients, and reduced CAB, cerebral blood flow velocity, in the context of absent systemic hypotension implies abnormal cerebral vasoconstriction at the arterial level. Simply, it means when you are standing up and to keep the blood flow preserved, the arterioles should open up. Otherwise, there will be drop of the blood flow because of the effect of the gravity. And we know from other studies, the cerebral vasoconstriction in the context when the orthostatic hypotension is absent is associated with inflammation of cerebral vessels and also poor cognitive functions. This was mainly shown in several diabetic studies. And also what is supporting this conclusion is that at least 2 studies did show elevated inflammatory markers in Lyme disease. Those are inflammatory vascular markers. And as I mentioned before, Dr. O could find out elevated CCL19 in Lyme disease. And we know from, again, other studies, there's those markers are associated with abnormal reactivity of cerebral vessels. So we speculated that elevation of ICAM and VICAM persists in PTLDS, which needs to be verified, but may result in inflammation-mediated cerebral vasoconstriction. Furthermore, reduced CBF due to cerebral vasoconstriction in PTLDS can result in cerebral hypoperfusion and brain fog. I'd like to show an example of what does it mean to reduce blood flow in PTLDS, and I would start with the POTS. POTS is postural tachycardia syndrome. It is relatively known syndrome, and this slide shows the tilt test in POTS compared to normal. So this is supine tilt, supine position, and this shows the heart rate, blood pressure continuous, end tidal CO2, and cerebral blood flow velocity measured from the middle cerebral artery. And normal response consists very mild increase of the heart rate, but stable blood pressure, stable end tidal CO2, and also stable cerebral blood flow velocity. This is typical POTS response. There is some tachycardia. This is by definition POTS, but the blood pressure is stable. There is absent orthostatic hypotension, and there is drop of the end tidal CO2, which drives drop of the blood flow. So again, in the POTS patient, they do have decrease of cerebral blood flow velocity, which is caused by end tidal CO2 decline. When we will adjust the blood flow for the effect of CO2, the blood flow will be stable. But this is a typical POTS patient, and we know that POTS patient is associated with orthostatic intolerance, with dizziness, shortness of breath, and brain fog. Essentially, similar symptoms they do have PTLDS patient. And now I'd like to show you an example of the PTLDS patient. This patient had a normal heart rate response. So this is a stable blood pressure. No, CO2 is stable, but there is a comparable drop of the blood flow as in the POTS patient. So again, this is POTS, and this is PTLDS. So this is a drop about more than 20%, which is significant. Brain is extremely sensitive to blood flow changes. Brain can tolerate huge swings of the blood pressure, but even few percent of blood flow decrease can result in dizziness or other symptoms. And for example, drop of the blood flow by 40% results in loss of consciousness and syncope. So it is feasible to assume that this drop of the blood flow results in cerebral hypoperfusion, perhaps in the memory problems, brain fog, especially considering cumulative effect of the orthostatic cerebral blood flow. So in conclusion, PTLDS or chronic Lyme disease is associated with small fiber neuropathy, which can be responsible for several pain syndromes. And PTLDS is associated with low cerebral blood flow, which can be responsible for brain fog and perhaps other cognitive complaints. And regarding origin of the small fiber neuropathy and abnormal blood flow, there are 3 possibilities. It is the same as a PTLDS. They can be immune mediated, or this can be due direct infectious mechanisms because of the Lyme, Borrelia, or because of the effect of co-infections. which are reported up to 53% of the Lyme patients. So the question arises, can we use the small fiber neuropathy as a biomarker? Probably yes, because it is quantitative and is objective marker, which is advantage. And also in theory, small fiber neuropathy, if done repeatedly, can be used as a marker of the disease response to any treatment or intervention. Second question, can we use PET scan, a glial activation imaging, as a biomarker of Ptlds inflammation? We don't have enough data, although the study I show you are very promising. Hopefully there will be some replication more in the future. And can inflammatory cytokines be used as a biomarker of Ptlds inflammation? Probably yes, although we know that CCL19, it is not specific to Lyme, but it appears to be a sensitive marker of inflammation in general. But again, as other studies, confirmatory data are needed. And thank you for your listening.